Welcome everybody on this progress report and complex exam. Let me introduce my PhD topic about the management of postoperative complications after third molar removal. My name is Eszter Hardi, and my vision as a PhD student is to improve the life quality of patients undergoing oral surgeries, and my vision is to find the best solution that alleviates patients' complaints after third molar removal. To achieve this, these are my current specific goals. I am investigating the effect of Vimix injection, kinesiology tape, and the different flap designs on postoperative complications after third molar removal. My first project is about the effect of perineural Vimix injection in reducing postoperative complications after third molar removal, which is a systematic review and a meta-analysis. Why is this topic important? Because impacted lower third molars are found in 90% of the general population, and about 85% of third molars will eventually need to be removed. And after this surgery, in the first 7 days, patients have trismus, facial swelling, and postoperative pain. So our question is, how can we reduce these symptoms? Well, Vimix anesthesia is a novel technique for mandibular anesthesia. What is Vimix? It contains local anesthetic solution and steroid, so dexamethasone. Addition of dexamethasone decreases leukotrienes and prostaglandins and increases the pH, and because of this, it decreases the pain, shortens onset, and prolongs the duration of anesthesia. So I compared the Vimix anesthesia and the conventional anesthetic solution, and my primary outcomes are the swelling and the trismus, and my secondary outcomes are the postoperative pain, the pain score on local anesthetic injection, the duration of soft tissue anesthesia, and the latency of anesthesia. The position of the included impacted third molars are in class 2, level A or B according to the Peg-Gregory classification. So my hypothesis is that perineural Vimix injection can reduce pain, swelling, and trismus after mandibular third molar removal. I did a systematic search in the main 3 databases with this final search key, and after the selection, I have 8 eligible full texts. Let's see the results. My first 2 figures are investigating the effect of perineural Vimix injection in reducing postoperative facial swelling on the first and third days. The measurements were performed on the first, third, and 7th day, but I'm only showing the first and the third days because these days are clinically relevant. So the facial swelling is one of the most important outcomes because it affects both the trismus and the pain. In this case, the facial swelling is obtained by subtracting the postoperative condition from the preoperative condition to obtain the difference in millimeter. Here the ideal situation would be 0 millimeter, which means there is no facial swelling. The facial edema was measured on different face lines, what you can see on that picture, and based on this, we made subgroups. The pooled effect sizes are highlighted in red below the figures, and we can say that the average edema is around 20 millimeter. So we can say that on the first day and on the third day, the facial swelling was reduced with 20 and 25%, which means clinically relevant results. My next 2 figures are investigating the effect of perineural Vimix injection in reducing postoperative trismus on the first and third day. The trismus is also an important outcome because it largely determines the life quality after the surgery. If there is a mouth opening limitation, then the speaking, the eating becomes difficult, and the maximum mouth opening becomes painful due to the muscle tense. In this case, the degree of trismus is obtained by subtracting the postoperative maximum mouth opening from the preoperative maximum mouth opening to obtain the difference in millimeter. Here the ideal situation would be also 0 millimeter, which means there is no trismus. Here the mean differences are highlighted in red next to the figures, and we can see that on the first day and on the third day there is a significant reduction, but neither day is clinically relevant. My next 2 figures are investigating the effect of perineural Vimix injection in reducing postoperative pain on the first and third days. The facial swelling is also an important outcome because it affects the quality of life, and this postoperative pain was measured on this 10 points visual analog scale. Here the ideal situation would be 0 point, which means there is no postoperative pain. we can see that the mean differences are next to the figures, and we can say that these days are clinically relevant. So the strength of this meta-analysis is that only RCTs were included and the analyses were performed at multiple time points, and the limitation of this meta-analysis is that not the same references was used in case of swelling. In conclusion, the TWIMIX significantly reduces the patient's swelling, trismus, and pain in the first 3 days. And we can say that the TWIMIX is a useful solution because no additional injection is needed. It contains low amount of steroids, so there is no complication, and luckily the cost is low. And the implication for research is that we should make more studies for better evidence, follow up on each day, use standardized measurement points, and we should include patients with similar patient's characteristics. So, unfortunately, after many rejection, now I submitted my paper in the Journal of Evidence-Based Dental Practice, and now it's under review. My second project is about the effect of kinesiology tape as an adjunct therapy in reducing postoperative complication in third molar removal, which is a randomized controlled trial. How I mentioned, in the first 7 days, patients have trismus, facial swelling, and pain after the third molar removal, and with this current treatment, the postoperative complications are still present. So our question is again, how can we reduce these symptoms? Well, we always suggest the cryotherapy after the surgery because it produces vasoconstrictions, controls bleeding, and decreases of this tissue metabolism. In addition, a new technique appeared, which is the kinesiology tape treatment. It leads to the activation of Mahari receptors by causing pressure, improving blood and lymph circulation. And it has many advantages because it's non-invasive, cost-effective, and continuously active throughout the entire application period. So I will compare the kinesiology tape with different tension and placebo, and the position of the included impacted lower third molars is in Class 2, level B, according to the PEG Gregory classification. So my primary outcomes will be the swelling and the trismus, and my secondary outcomes will be the pain, the painkiller intake amount, the kinesiology tape discomfort, and the quality of life. So my hypothesis is that kinesiology taping with 40% tension is more effective than other tension and placebo in reducing postoperative swelling, trismus, and pain after mandibular third molar removal. So I finished the protocol drafting, and now finally we got the sample size, which is 82 patients per group. And let's move on to my third project. I'm investigating the effect of different flap designs on patients' morbidity after lower wisdom tooth removal, which will be a network meta-analysis. So we know that surgical removal involves the manipulation of both soft and hard tissues, and it is usually associated with a number of postoperative complications such as pain, trismus, facial swelling, and periodontal diseases. And what could be the influencing factor? For example, the incision and the flap design. So my aim is to assess which are the best types of flaps that can be used to reduce postoperative complications after lower third molar removal. So I will compare these different flap designs, and my primary outcomes will be the swelling, the pain, and the trismus, and my secondary outcomes will be the alveolar osteitis, periodontal condition, and wound dehiscence, and the operation time. So I did a systematic search, and finally we got 44 eligible full text. And here you can see the overview of my free project. And here you can see my additional activities. I have been interested in this topic during my university years. So my TDK topic was the pre- and postoperative complications after lower wisdom teeth surgery. And in the last 2 years, I have been reporting my PhD results in many oral surgery congresses. And with this last slide, I would like to thank you for your attention. With a quote, "A goal without a plan is only a dream." Thank you.
My question is regarding your second project that Will you have a policy for the brand of the kinesiology tape? Because as I know that there is a brand, the first one, but you can have it like the Hardi or a pharmacy. And is there a difference between the different brands of the kinesiology tape?
Thank you for your attention. Well, yes, we have many different kinesiology tape and different brands, yes. Yes, there is a difference between, because some kinesiology tape is not waterproof, for example, and it's really important because patients after the surgery go to the bathroom and shower, so it's important to stay there. So yes.
Thank you. And just another question regarding this, that for example, the tape has different colors for the patient's satisfaction. Will you use different colors, or there will be just the brown one or the black one?
My plan is to use one color, but I think it's never mind. I don't see a significant background, so.
Thank you very much.
The kinesiotapes, I don't know them. I just see on the runners here and there. But you mentioned there are 2 strengths, actually 3 used. Is it how should you? Well, is it due to the application, or the tape itself is characterized as 40% or 20%?
Yes, the tape. So. In this case, we will measure this part. So we will measure from the trigoscalene line to the supraclavicular lymph nodes, this distance. So, and after that, we will shorten the kinesiology tape with 20% or with 40%. So it will be shorter.
But the same tape,
yes, same tape.
The flexibility of the tape is the same, except the length you change.
Yes, yes,
okay.
yes.
Okay, thank you. But I would join with the question of regarding the colors, because that's we should not discard the placebo effect.
Yeah.
If you get a blue one, you might feel it less painful than
placebo.
If you get a red one.
Yeah.
Congratulations for your progress. Like, if I cannot use the twin mix injection for any reason, like, what would be the best measurements or instructions given to patient to minimize trismus, post-operative pain and swelling, like as a clinical practice?
So your question is how?
What is the best measurements or instruction given to the patient? Like, if I cannot use the twin mix injection, if I use the conventional technique?
Well, I think we should use the steroids in the everyday practice if we can do it. But so your question is, how can we measure it?
No, like, what is the, if I cannot use the twin mix injection, like, how can I, like, instruct the patient or minimize my efforts?
Okay. How I mentioned, I think the cryotherapy after the surgery is the best and the easiest solution. But yes.
It would be the ice pack?
Yes, ice pack on the face, yes.
Thank you.
I have only one comment, probably that could be answer on your question. Because we all know that this kind of diagnosis and surgical extraction of the wisdom tooth can last very long time, 40 minutes, 1 hour, which is indicated for some kind of treatment post-op, or it could be very quickly if the position of the tooth is not complicated, and we really don't need these things because these corticoids, we don't need it all the time.
Yes.
Other thing is we can go for conventional methods with anesthesia, and then if the surgery was hard and we predict that could be a problem and trismus and harmful impaired healing, we can add after the surgery dexamethasone inside.
Yeah, I absolutely agree with this. Yes. No.
more or less my question was already answered. Thank you. You mentioned some limitations regarding differing references for the studies for your first project. By references, you mean control, like the standard of care or the protocol of care in the control groups? Or what did you mean by those limitations?
Thank you for your question. Well, I mean that the facial swelling was measured on different face lines, and how you see, we collected these results into one forest plot, and this is why I said that there was a difference in the measurements.
Okay, and with the wisdom tooth removal, so is it like control meant the same standard of care for all patients, for all studies, or did they differ based on local traditions and stuff?
Almost the same. For example, the painkillers was different, but I think it won't be influence our results in case of swelling and in case of trismus. But yes, of course, for example, in the pain, yes, it could influence it.
Okay, thank you.
Do you have any data how many % of the manuscripts or the articles were split mouth designed?
Yes, but I'm not 100% sure. 2 or 3 was split mouth study.
Yeah, because actually that would be the most valuable, because the same patient reacts for the same or different therapies.
Okay.
Congratulations, first of all. I also have a question regarding the twin mix, the steroids. I'm not sure generally what's the incidence of post-operative infection in such operations, but do you think the twin mix, or do you have any information whether it affects this incidence?
Unfortunately, in these articles, they didn't mention for example, the alveolar osteitis or periostitis.
Okay, thank you. And also I have another question regarding all of your studies. If I understand correctly, then your baseline is the preoperative status. So does that mean you only include patients who are completely asymptomatic before operation?
Can you repeat your question?
So the patients that you have included in your study, or that these studies included, did not have any symptoms of, for example, pericoronitis or anything prior to the operation?
Yeah, it was a inclusion criteria, so my answer is no.
Okay, thank you. And I'm just wondering that if in your clinical study there is a potentially eligible patient who does have such symptoms, do you conservatively treat them and include them later on, or immediately exclude them?
First, conservatively, we should treat them.
Okay, thank you.